Good morning, everyone.
Good morning.
Good morning. We will start in a few more minutes.
Perfect. Thank you, Andrea.
Good morning, everybody. Good morning, Diego. Buenos dias. Good morning.
Hey, how are you, Joe Paulo? How are you?
I'm
Buenos
good.
dias.
Good.
Bom dia. What to say?
Estoy a tentar mejorar un poquito mi español también.
It's great. Perfect.
Great. Thanks for being with us today, Diego. Really appreciate that. And thanks everybody for joining. We can give like 1 or 2 minutes so everybody is I know everybody's logging in now. The residents have finished rounding, and we're gonna have a great morning today.
Thank you very much for the invitation to all. I really appreciate it. Thanks for the opportunity to share some time with you guys.
Oh, it is our pleasure. This morning, I'm not sure if Dr. Quinones himself will be able to join as well, because we have actually yesterday and today the ABNS exams in Phoenix, so he's there. I know he was planning to join if possible, but we're definitely going to do our best to represent, and he is very excited to have you here with us, Diego, today. So thank you so much for taking the time and joining us.
Thank you very much. I completely understand. If he said that he was in doing the tests, right?
Yes, exactly. Yeah, that's
yes.
the
Please
ABNS.
send him my best wishes, and we'll try to do our best here, showing some cases of how we do these things in Latin America.
Perfect. I mean, I know your work very well, so I'm sure that it's going to be pretty exciting. Thanks so much for joining.
Thank you,
So
Joe.
Oh, my pleasure. So we have here as well Dr. Susan Sampson. Diego. Dr. Sampson is our chair of endocrinology. So basically, she's our boss.
Okay.
And we also have, I see here Dr. Vargas from Colombia, who is basically he's a Mayo Clinic member. He's always with us, and we always benefit of having Gabriel with us. Thanks. Gracias por juntarnos a nosotros, Gabriel, hoy.
No, thank you very much, Diego. Good morning. Thank you.
Hello, Gabriel.
And of course, we have a big team of residents, international participants, of international faculty, and the goal is to have this as an international symposium for surgery, surgical techniques, anatomy, and case discussion. So thanks very much, everybody, for joining us. Today, we're going to start with Dr. Marenko, who's going to be presenting a case we had here at the Mayo, Florida, about a month ago or so. And then we're going to follow by Dr. Rosito. So Lina, please go ahead.
Thank you, Dr. Almeida. I'm going to start sharing screen. Can you see my screen okay?
Yes, perfect.
Okay, great. So today I'm going to be presenting a case of a suprasellar lesion. The surgery was performed by Dr. Chichana, Dr. Almeida, and Dr. Olomu. So first, just to take some time to acknowledge each and every member of this multidisciplinary team, Dr. Chichana and Dr. Almeida from Neurosurgery, Dr. Olomu from ENT, Dr. Sampson from Endocrinology, Dr. Desai, Radiology, and Dr. Gentle from Pathology. This is a case of a 46-year-old right-handed woman whose chief complaint was visual decline. So in late January 2022, she went to an ED at an outside institution complaining of vision loss in her right eye and monocular visual distortion as if she was looking through raindrops. They performed an ophthalmological evaluation there, which showed a decreased visual acuity in the right eye with mostly inferior temporal changes. They performed a CT scan and an MRI, which revealed a suprasellar mass. And in March of 2022, she was seen by endocrinology here at Mayo Clinic by Dr. Sampson, who referred her to neurosurgery. Review systems, she complained of her visual problems and loss of balance. Otherwise, it was non-contributory. Her physical exam was grossly normal. The patient was obese. She was awake, alert, and oriented. She did not have any facial plethora, proptosis, periorbital edema, or fat deposition. She didn't have any cushingoid facies, no hirsutism or acanthosis. And her visual fields on examination were photoconfrontation. This is Dr. Sampson, if you want to talk about her preoperative endocrine labs.
Sure. And even if you could go back 2 slides, there was a little subtlety here that was very interesting.
Okay.
One more.
Yeah.
She had talked about her hunger increasing exponentially. And her outside physician had actually put her on phentermine, but also liraglutide, which is a GLP-1 agonist and decreases appetite via hypothalamic mechanism, among others. So it's really interesting because she's a suprasellar mass that could be impacting her satiety centers in the hypothalamus. And so when she was given the liraglutide, that very strong appetite increase that she had actually was abated. So that was one of the interesting things about her history. And then I also think that past history of melanoma was important because you want to make sure that you're not thinking about a metastasis to the pituitary. And the key there would be, for most metastases, probably 80%, does she have diabetes insipidus, symptoms of diabetes insipidus? And if she doesn't, you can kind of move away from that diagnosis. And then with these labs, when you see this mildly elevated TSH with normal free T4, that could be evolving hypothyroidism, which makes you think of, could she have an autoimmune background? And in this 46-year-old woman, is it possible that this mass is actually in hypophysitis? So there's a lot of very broad differential diagnosis for this particular mass, barring the appearance on MRI. The rest of her workup was pretty healthy. I later was able to get an ACTH and cortisol preoperatively that looked adequate. But given the nature of the mass, I was sure that my neurosurgery colleagues might need to give dexamethasone depending on the course of the surgery.
Okay, these are her preoperative scans. And here we can see this suprasellar mass that is homogeneously enhancing and is abutting the internal carotid arteries with some medial invasion to the optic canal and optic nerve. And then on a sagittal T1 postgad, what we can see is how this mass appears to be originating from the tuberculum sella and is pushing the pituitary downwards and is pushing the chiasm upwards and posteriorly. Additionally to this mass, the patient also had a mass along the left side of the clivus, homogeneously enhancing dural-based lesion, presumed to be a left clival meningioma, which was asymptomatic. I see that Dr. Desai is online. I don't know if you want to, Dr. Desai, if you would want to comment anything else.
No, I think you described it well. It's a very homogeneous enhancing mass within the anterior sella, kind of centered at the tuberculum, and it has a pretty smooth, well-defined margin. It has a smooth internal texture on the T2-weighted images that you're showing there. We can see that it's abutting the medial margins of the internal carotid arteries, but it doesn't look like there's any invasion of the cavernous sinus. It's extending into the suprasellar cistern and pressing up against the optic chiasm, which is superiorly displaced and slightly stretched. And that image that you're showing right there also shows that the prechiasmatic optic nerves is those two dots, which are on the superlateral borders of the tumor. So it's causing some mass effect on the optic nerves, but we didn't see any definite signal changes or atrophy of the optic nerves.
Okay, thank you.
Yeah, what is, if you look as well, like, so when we look at this image in there, like with a hyper-enhanced homogeneous lesion, or a first hypothesis is suprasellar meningioma. And it is interesting, I'm just mentioning this now because the coronal T2 image, as you look at that, when we think about suprasellar meningiomas, we think about tuberculum sella, we think about planum meningiomas, and the really difference is, and then I would say, and when you look once again at the coronal T2 image, it is important to differentiate when we think about tuberculum meningiomas and you think about meningiomas actually arising from the diaphragma sella. So that T2 image is one that helps us to differentiate that, because you can see at the bottom of the tumor, so if I just annotate here, that there is a small renal CSF right here. And that renal CSF between the tumor and the diaphragma helped us to differentiate in terms of that attachment as well. Because what happens with those meningiomas arising in the suprasellar space is that we use names like tuberculum, planum, diaphragma, distal dural ring, etc., but they're all the same layer of dura. And the tumor tends to extend and run through those attachments. But this differentiation, if the tumor is attaching to the prechiasmatic sulcus primarily, or attaching to the diaphragma sella primarily, helps us in terms of surgical planning and guidance here. So in this case, we had this tumor that was arising, as Lena said, primarily from the tuberculum sella here, and pushing the pituitary gland downwards and the optic nerves upwards and sort of like backwards. A very, very important point in this case is to look at the optic canals. So if we scroll the image, I think the coronal T1 post-gadolinium has a bit of thinner cuts rather than the T2. Go back a bit, please. More. Yeah, right there. I'm sorry, right there. Back. Yeah, right there. So what we see right here, so this is the optic nerve on the right. This is the optic nerve on the left here. And what you see here is this tumor. There is a planum component here. And you see this tumor that is basically occupying or invading the medial aspect of the optic canals, especially on the right side, which is compatible with her clinical symptomatology in terms of visual decline more prominent on the right side. Looking at this case with bilateral invasion of the medial component of the optic canals on a tumor that is mostly on the midline, and with the caveat that we have to look, can you scroll a bit the T2 image here? That we have to look at the, go back, yeah, right there, that's fine. That we have to look at this extension of the tumor. So this is the end of the clinoid ICA, and this is the region of this of the distal dural ring. So those meningiomas can extend and attach to this area. And if this tumor would extend more laterally here, it would not really be an ideal case that we could resect completely most of the time. It would leave like a tail of dura here in this area. But in this case, it reaches the mid-top part of the distal dural ring. So although we cannot really separate the distal dural ring, we can train it all the way to the end of the distal dural ring in the carotid and coagulate whatever is left in that area and maximize the tumor resection. And the other side, that was not really a problem here. And the other thing, we don't see any arterial encasement. The arteries are all pushed upward, so that facilitates our work. And the big issue here will also be to preserve the superior hypophyseal arteries that are running from usually the clinoid or supraclinoid segment of the ICA and supplying the stalk, which is preserved at this time, in the optic chiasm. But I'd like to ask Diego. Diego, looking at this case, let me just erase all my notings here. How do you look at this, and how do you consider this for surgery, and Dr. Vargas as well? And of course, all the team members here present.
Yes, this is a very interesting case, where one of those cases where the different surgical techniques get combined, and there's always like both sides of the coin in a way. It's a very nice, well, not nice, but it's a very it's a very nice tumor in the suprasellar region, with this tuberculum cell that seems to have a tuberculum cell invasion. Very interesting that it also has a combined. It has an additional tumor in the small one in the petroclival region. And as you said, Joe Paulo, completely agree with all the concerns about the preserving the appropriate irrigation. Very important to preserve the irrigation to a pituitary stalk, and to have not as much manipulation to a pituitary stalk, and the such importance about the invasion to the optic canal. So those are very important concerns that we have to try to look at the image in order to decide what is the best option for this patient. But definitely we'll need a surgery.
Perfect. Dr. Vargas, any input that you'd like to share with us?
Yes, this case is a difficult case because you don't know exactly if the tumor is going to be very soft in order to do an endoscopic endonasal approach, which is the first option if you see the invasion of the sella. But the problem is with the optic canal invasion, that is not easy, and you need to do a good technique in order to decompress that nerve, and maybe you're going to be in trouble. So, but I try at the beginning to really decompress the optic nerve and the carotids on the sides, and try to do an endoscopic endonasal approach. But also, of course, you can try craniotomy and the classic decompression, but in this case maybe you're going to left some tumor inside the cella because of the vision. It's not good through the subfrontal or whatever pterianal approach that you do by open access. So I try to do at the beginning endoscopic endonasal approach and see if I can work with the carotid and with the nerve, of course taking care that, as you say, maybe I need to left some tumor because it's not easy. And sometimes these kind of tumors get the sensation that you work a lot and you are in danger of the carotids and the nerves, and how to push and how to try to take the tumor. So these kind of tumors, maybe you need to think it's better to left a little piece, but not to damage the important parts here that are the carotids and the nerves, optic nerves.
Thank you very much. I fully agree with all the points, and you're going to see in this case that let Lina continue just for the sake of time, and let's go ahead because I want to make sure that Diego is going to have his proper time that we're going to show the case and so.
Okay. So for differential diagnosis, we have meningioma, pituitary adenoma, and treatment options include surgery, which can be through traditional open transcranial approaches or endoscopic endonasal approaches. Like Dr. Almeida said, there's several factors to take into consideration to see if which approach is best to use. Usually if the tumor is large, if there's lateral extension, or if there's encasement of the vessels, it's better to do an open transcranial approach versus an endoscopic endonasal. Radiation and observation are other options. Dr. Almeida, I don't know if you want to comment on this.
No, I fully agree. For the sake of time, I think the rule of the thumb is that if there is a lateral extension lateral to the clinoid and optic nerves, an open approach is usually better selected. We also have the options of combined approaches, of course, the options of like dividing it in 2 steps, and the radiation is really not a very good option when we have a tumor like this. You can always try fractionated if the patient cannot, for any clinical reason, tolerate surgery, but it's really not ideal when the patient has this degree of optic nerve. So, of course, the patients develop symptoms as young, and so surgery definitely is the way to go here.
Okay, because the patient had elevation of the chiasm, visual decline in her right eye, invasion of the optic nerve that was more medial, and because you had that component of the tumor that extended inferiorly, the plan was to go ahead and do surgical resection through an endoscopic intranasal transtuberculum transplanum approach and medial optic canal decompression for this tuberculum cell meningioma. For the meningioma, because it was small in size and it didn't have symptoms, it was decided to go ahead and observe with serial imaging. So this is her preoperative CT. I know Dr. Olumu is online if you want to comment on the imaging for the planning.
So for planning, in this case, we look at the septum, we'll look at the nasal components, turbinates, middle turbinates. Then in the sphenoid sinus, we look especially at the intersinus septation and their orientation with the internal carotid arteries. She did have a septal deviation towards the right side. And so there was a plan for potential septoplasty as well, if this was obstructing our access to the sphenoid sinus.
Risk and complications are listed here: hemorrhage, CSF leak, acute hydrocephalus, delayed epiphysis, new endocrine deficits, worse visual outcome, new neurological deficits for mortality. The patient was positioned supine, reversed in Dellenberg, no head fixation. The arms were kept along the body. The right leg was prepped for fasciolata harvest. Lumbar drain was placed, and neurosurgery and ENT worked together on the right side of the patient. Just for time,
maybe we can go to the video.
Yeah. Okay. So I'm just gonna go ahead and play.
So, Noma, if you want to just describe like the first part that.
Yeah. So the first step, because we are expecting a CSF leak going transplantar, so tuberculum, I am elevating a nasal septal flap. So this is coming off on the left side. So first I'm outlining the pedicle of the nasal septal flap. The first incision was on the floor of the nose. It's going to have to be a long flap because we have to get up to the planum. And so I'm bringing the flap very far anterior, essentially almost towards the sill of the nose. Now we're elevating in a subperichondrial plane, which is important because that is what provides a good repair. So I'm elevating the mucosa off the floor of the nose here, and then dividing the superior aspects of the flap here. So I'm using a suction elevator here, which is really good for elevating the flap. So there we have the flap. You can see its pedicle, and then we'll tuck the flap into the nasopharynx for the rest of the case. So that's, yeah. So after elevating the flap, now I'm proceeding with the sphenoidotomy. So there we've created a small posterior septectomy, an appropriate posterior septectomy. And now I'm using a sonopet to drill down the intersinus septations to get full exposure of the sella.
Perfect. And after the, after the nasal phase, the approach was completed, as Dr. Alomo described pretty beautifully. We went ahead, and in this case, we have to, identify some of the landmarks. Basically, we have to think about all of this in 3D. So here with a diamond and drill, basically, I'm drilling getting everything flat in the base of the posterior part of the sphenoid. And after that's done, we go and we start thinning out the bone around the sella, and then thinning out about the bone. You see here on the left side first, the left optic canal and the bone around the left clinoid segment of the ICA. Same steps are done on the right side, on the right optic canal, until we see the right, basically the right clinoidal ICA thinned out. So basically, on this area here, was the right ICA. Here we got the left canal. Here we're gonna get the left ICA, and here the right canal. Now what we're doing here, basically I'm drilling from the roof of the optic canal to the roof of the optic canal. And this line is called the limbus here. And then we basically, after thinning all of that, we can start elevating the bone. So the bone of the cell is elevated. I got used working with double ball probe because of the work in the lab. So I just got, I like using that. After that, we have to remove the bone. And in this case, as described, we're going to expose both clinoid segments of the ICA to maximize the work on the angle above the supraclinoid ICA, as you're going to see in this case. After that's done, we have to continue exposing. So here, just really right medial to the right supraclinoid ICA, and once again, elevating that bone. So bone is thinned out, and after that is elevated away from the carotid and away from the optic canal. I'm sorry, the optic nerve. So I always like to palpate and also to check with the Doppler. The double ball probe to me just facilitates that maneuver to free out and elevate all that bone. And once again, it's meningioma, so we're gonna have to expose the dura to the best of our ability so we can remove it all and to try to deal with this in a safer fashion. So here on the left side, working on the top, and this is the vision that you get at the end. So you got to translate that vision into your surgery, and this is what you get here. Stop the video for a moment. Oh, can you go back and stop the video for a quick second? Yeah, right there, that's perfect. So what you see here is the right clinoidal ICA. This is the right optic canal. This is the left optic canal. This is the left clinoidal ICA. This is the sella dura. This is the communication of the top of the optic canal to the top of the optic canal, which is the limbus sphenoidale. And this is the small planum or transplanum extension that we did in this case. So this is the area that we're going to have to work on the tumor. Lina, go ahead. Let's continue for the sake of time. So here is ligating the superior intercavernous sinus. And then we're going to transect. I always like cutting below the superior intercavernous sinus and above the superior intercavernous sinus. You can skip the move ahead a bit, Lena. And then after doing that, as you open the dura, that's the tumor right there, because the tumor was attaching to that dura in the prechiasmatic sulcus. Here I'm using a feather blade and opening the canal on the left side first. Why did I start on the left side? Because the left side is where I know there is not as much tumor as there is on the right. And this exposure of the carotid and the optic canal allows us to do this demobilization here, which is mobilizing the tumor away from the arachnoid plane, which is going to be the layer of preservation from all the vascular structures on the left side. On the right side, on the other hand, we knew that the tumor was extending quite significantly on the optic canal, and therefore it was going to be more difficult to get all that extension. So although the goal was to remove all the tumor in the optic canal, I knew that we may have to find a plane, create a plane with the distal dural ring and the right clinoidal ICA in order to mobilize that. This tumor, as you see here, was, I wouldn't say necessarily super soft, but was somewhat soft that facilitated some debulking. And what we get to see now is that we are mobilizing it from this left supraclinoidal ICA. I'm using sharp dissection. We are cutting it away from the diaphragma sella and separating it from that plane, although the tumor was not really arising from the diaphragma, but there was some attachments. And then as we do that, you see that we are working right adjacent to the clinoid ICA. So stop the video right there. So this here, this is the right clinoidal ICA, and this transition to the supraclinoid ICA. This is going to be the distal dural ring. And this, once again, here is the optic nerve and the optic canal. So this requires a lot of microsurgical dissection, a lot of sharp dissection, and definitely like with a Doppler, it can help you that, but it's a lot of 3D anatomy that you got to keep in mind. Let's keep going. Then you're going to see in the left side, you're going to have exactly that same view. We're going to mobilize the tumor away, and then we can see the ophthalmic artery here originating from the carotid, and we're going to start to see the optic nerve on the left side. Lina, you can skip maybe just a bit. And then more the bulking to be able to mobilize that. You skip a bit more. Then opening it more on the right side to be able to separate that tumor. And we have already separated from the pituitary stalk, but stop there. Oh, sorry. You're right there. So what you see here is the pituitary stalk, and the little vessel you saw coming on the right side, that was a superior hypophyseal on the right side. And we can coagulate the one going to the stalk, considering that you got the one on the left, but careful with putting or hypopit afterwards, but keep that in mind. So go ahead. You got to preserve the branches going to the optic nerve though. So you got to be careful, and that's got to be done very selective. So once again, the tumor mobilization continues here, creating a plane away from the distal dural ring, which I know I'm not going to be able to separate from the carotid just because it's adjacent to the carotid wall, and coagulating that branch of the superior hypophyseal artery going to the stalk. And then we transect that and we mobilize it away, and you see just the anatomy again. Skip the video a bit, Lina, just for the sake of time. Yeah, perfect. And then here, once again, coagulating some of the branches going into the tumor and preserving the other branches of the superior hypophyseal on the left side. So that's got to be done very carefully and very gently. You don't want to go ahead and cut those branches because some of them will be going to the optic nerve. So you got to be very selective with that. That's why we're coagulating and cutting and mobilizing it. After that's done, you can see the supraclinoid ICA beautifully on the left side, and you can see the bifurcation of the ICA there, A1 and M1 going on the other side. Then you preserve the plane of arachnoid and you dissect the tumor away. Can you skip the video a bit for the sake of time? Okay, continue, skip the video a bit more. So you're just preserving that arachnoid plane, skip the video. And then with a 30-degree scope looking at the right side now and using a Castelnuovo dissector, which is a bit of an angle dissector, we're looking all the way to the right side. So that's a pretty angled view that you got there. We are mobilizing that arachnoid away, and we're going to start rotating that tumor. So we are once again transecting with the attachment with the distal dural ring. And then basically I'm going to go ahead and mobilize. And as I was trying to rotate that, we were kind of like lucky enough that the tumor was already, disconnected. And then we could just go ahead and basically get the tumor out. And then this is the view that you get after the tumor is resected. Basically the optic nerve on the right, this the ophthalmic artery going to the right side. And here I'm coagulating the attachments to the distal dural ring, as you see there. And the optic canals are completely decompressed on both sides. You can see the pituitary stalk preserved, the pituitary stalk is preserved, the left ICA, ACOM complex, A1 on both sides, and then the reconstruction with a biodesigned dura matrix and a vascularized nasoseptal flap at the end. Let's just skip. I can just share the rest of the case with the team. Just for the sake of time, I want to be respectful with Diego. The patient did well neurologically, thankfully had an improvement in the vision on the right side. She was quite happy about that. We were able to get a gross total resection of this tumor. Afterwards about, I'm sorry, Dr. Gentoff, if you want to share just a couple of pearls with us. I don't know if Dr. Gentoff is here.
Dr. Gentoff is not here. He just sent the slide. So we're just going to skip. The diagnosis was a meningioma, WHO grade 1.
Perfect. Thank you, Lina. And then unfortunately, this patient had to return to the hospital with a CSF leak. Initially was an attempt with fascia lata and flap. This, worked for a couple of weeks, but she came back with a second leak. And Dr. Oloma, I was not in the second repair, but if you want to just share what was done the second repair right while Lina shared the video.
So these defects can be, they're three-dimensional defects that can be challenging to fix because you have the posterior sellar portion and you have the superior anterior planum spinodalis portion, and it looked like the even the flap had some, essentially the flap had some necrosis around the distal tip. So in the first repair, we removed the necrotic portions, replaced the flap, and that seemed to work for a few weeks. And then a second time, she had a leak coming from superior. So this time I removed the first flap completely, elevated a second new flap. And what we did differently this time was we performed a rigid repair, so so-called gasket seal. So you put down a layer of biodesign. Well, first I put a little gel foam and some Surgisil, because there was a very small hole in the arachnoid that was leaking. Then put down some biodesign and then put a piece of cartilage in a gasket seal approach to provide essentially rigid support of that region. And then afterwards, I put some Surgisil around the edges and then put the new nasal septal flap. So this was a defect that, in retrospect, needed a rigid repair, just because partly her habitus and also the location and geometry of the defect. But that appears to have resolved that.
Perfect. Yeah, the patient did well after this. She is continuing on Diamox, but she was discharged, and thankfully she's doing very well. I know we have plenty of comments. Alina had worked on a few more details for us to discuss, but we got very excited with this case, I think. And I do want to be, respectful with our fantastic guest speaker today. So I'm sorry, I'm going to stop this case right now, and I'm going to invite Dr. Diego Garcia Mendes to present. Who's going to have the pleasure to introduce Diego? Myself or?
So Paulo, can I talk about your case?
Absolutely, yeah, sure.
Yeah. It's such a beautiful case. Such a beautiful case, as you showed. You can have very, very good dissection from below, preserving beautifully the vascularity, obviously always with the risk. There was some years ago, perhaps, some discussion about if you do it through a craniotomy or endoscopic. Some would say that by that time they would say, oh, the optic canal. But you showed perfectly how you can decompress the optic canal medially with that dissection. So I think it's a very good thing. But on the other side, the thing about the risk of the CSF, So it's something that it's very nice that you guys showed it, because it's something that shows all the evolution of your team, the experiences that you get, the good ones and the ones that trying to improve. So it's a very, very nice thing about showing it. And those cases are very good for learning for the complete team, for the reconstruction, and it's something very, very important, the reconstruction in those cases. Thank you.
Thank you so much, Diego. Really appreciate your words. Well, if nobody's going to fight to introduce Diego, I'm going to fight to introducing myself.